Hello, everyone. This is André from the Mental Health. I'm here with Sorana. Would you like to introduce yourself?
Sure. Hi, I'm Sorana Berry. I'm a clinical psychologist working in Berkshire Healthcare Trust, and I head up a specialist personality disorder team called Impact. And as part of our service, one of the pieces of work we were presenting today, actually yesterday, was our Assist project.
And this is all about helping people who are in crisis, trying to help them sort of stabilize.
Yeah.
So tell us a bit about how you do that in Berkshire.
So, what we've been doing over the last few years in Berkshire is looking at how we can provide a 12-week or up to 12-week piece of work to support people that might be coming out of inpatient acute settings or long-term rehab placements, or that may be on the brink of admission or being considered for admission because of severe distress and crisis that they might be experiencing. So we're trying to look at how we can prevent long-term admissions that are unhelpful and just don't provide therapeutic interventions, or support people that might be revolving door in and out of inpatient hospital settings for short stays, but repeated and over a period of long time. So this up to 12-week piece of work has been developing over a period of time, and we've been looking at what is it that actually works? What is it that supports people to stabilize? And what does stabilize even mean? So what we've known is the principles behind what could work and what would work, such as client-focused interventions or pieces of work, relational building, trust-building relationships with people in a way that means that they do feel supported to step out of inpatient settings and not feeling like they have to have that containment, as it were, by being literally contained and held in a hospital setting, and bridging and supporting people to access the stuff that we know does work. Therapeutic interventions, or making use of community mental health teams in a way that is helpful to them, or accessing things like our service user network and building connections and supportive network around the person. We kind of knew the principle behind what would work, but we weren't quite sure what were the actual tools that we were drawing on, because it seems that the people we were working with were getting, I suppose, a hodgepodge is maybe the wrong word, but it depended on who they were working with in the little team of assist that we have, what they were getting. So if they worked with a psychologist, they might get a particular piece of work. If they were working with our mental health nurse, they might be getting something else. If they were working with our OT, they might get something else. So what was important for the team is to try to tease out what were the tools that they were drawing on, what was the menu. And so what we were presenting in our talk yesterday was what we came to, what we distilled as a kind of menu of offer, and how we structured that.
I guess you're talking about helping people sort of step back from the brink in many ways.
Yeah.
And people that have this diagnosis of personality disorders are often not helped that effectively by our health systems, or maybe, even kind of harmed or stigmatized by our health systems and the people that work in them. What advice would you give to people working in emergency services, people who aren't necessarily mental health professionals, for how they should support this group of people? Is it just really simple, like, be kind, try and build trust, try and build relationships? Is it that obvious?
At the starting point, it absolutely is that obvious. Be human, be kind, listen, care. So it is those basic human things, really. But once you through that, people did also want more specific support with specific areas of their lives that were leading to the distressing point. So what we put together was a menu that listens to that. So it starts with, what do you need? What's going on for you right now? What's led to this crisis, or, escalation, if you like, of distress? How can we get alongside you and how can we get alongside the rest of the system that's working with you right now? Because what assists don't do is take people on as a referral, a handover. So often in mental health services, we find there's, okay, you take this problem, you sort it out, and then give it back to us fixed. And it just doesn't work that way. So what we've tried to do with Assist is get alongside community mental health team practitioners and just boost up the support that they're trying to provide, because we know CMHTs don't have time or don't have capacity or are stretched or are frightened. So it is just bringing along that additional boosting up of support for that person and listening. What is going on now, and what are some of the things that would help you in this piece of it's a short piece of time, really, 12 weeks. It's not that long. So the intention isn't to fix everything and hand it all back shiny and new. It's more about, we know that this is a particularly tough time. What's that about? What are the things that could help you? And work from the beginning of that 12-week piece of time towards handing back to, or handing forwards, or bridging towards something that perhaps people were not managing to access before that piece of work.
Brilliant. Thanks so much for sharing.
You're most welcome. Thank you for asking.